Very good morning, everyone. Dr. Hamid is here. In previous lecture, we talked about anticholinergic drugs. We classified anticholinergic drugs into antimuscarinic, ganglion blockers, and neuromuscular blockers. We talked about antimuscarinic drugs. In this lecture, we are going to talk about neuromuscular blockers. In this diagram, you can see one motor nerve ending and one muscle cells. This motor nerve ending is the nerve terminal or nerve ending of somatic nerves, and we have discussed about this that somatic nerves, they release acetylcholine as a neurotransmitter. This acetylcholine, when it released into neuromuscular junction, it binds to nicotinic receptors which are on the muscle cells. These are nicotinic receptors. All you know now that nicotinic receptors are made of 5 subunits. 2 subunits are alpha subunits, 1 subunit is beta subunit, 1 subunit is delta subunit, and another subunit is gamma subunit. And between the alpha and gamma and alpha and delta subunits, we are having sites for binding of acetylcholine. When this acetylcholine is released in the neuromuscular junction, it will bind to this site only, and by binding to this site, it opens the sodium channel, and by opening the sodium channel, we can see flowing down of sodium into the muscle cell, and this sodium, flowing of the sodium, it will cause depolarization of the muscle cells, and that will lead to contraction of the muscles. Contraction of muscles. But this is not that much easy. After the polarization, there should be releasing of calcium and so on, and that will lead to contraction of the muscle. This was about the releasing of acetylcholine from the motor nerve ending, binding of acetylcholine to nicotinic receptor, opening of the sodium channel, and depolarization of the muscle cells. Now, these neuromuscular blockers, on the basis of their mechanism of action, some of them are agonistic for these nicotinic receptor. And by this mechanism, they can cause repolarization. I will explain about that. And we call them depolarizing neuromuscular blocker. Depolarizing neuromuscular blocker. Because they can cause depolarization in the muscle. But some other chemicals are antagonistic for these nicotinic receptors. How they work? They can bind to the nicotinic receptor, they occupy the nicotinic receptor, they inhibit binding of acetylcholine to its site of binding. And when it inhibits binding of acetylcholine, the action of acetylcholine on the muscle cell will decreases, and that will lead to, instead of the polarization, it will lead to repolarization and relaxation or the paralysis of the muscle. These type of chemical which are antagonistic for nicotinic receptor, those are non-depolarizing neuromuscular blocker. Non-depolarizing neuromuscular blocker. So we have two groups of neuromuscular blocker on the basis of their mechanism of action. One is non-depolarizing, they are antagonistic. Now all we know that they are antagonistic for these receptor, antagonist. And we have depolarizing neuromuscular blocker, and those are agonist for nicotinic receptors. Now, first we'll talk about non-depolarizing neuromuscular blocker, and then we'll talk about depolarizing neuromuscular blocker. On the basis of the duration of action of non-depolarizing neuromuscular blocker, we can classify them into 3 groups. One is short-acting. Second is intermediate acting. and third is long-acting neuromuscular blocker. Long-acting. And in each group, we have two different chemicals with different chemical structure. One of the chemical structure, one of the groups which we are having in short-acting are isoquinoline group of drug, and another one is a steroid group of drug. In isoquinoline short-acting non-depolarizing drug, examples, for example, D-tubocurare, tubocurare. And steroidal, for example, panchronium. In intermediate, also we are having one isoquinoline drugs, and another also we are having steroidal drugs also. Isoquinoline in intermediate acting non-depolarizing neuromuscular blockers, for example, etracurium and cis-etracurium. And in steroidal, for example, we are having rocronium. In long-acting also, we have isoquinoline group of drug, and steroidal drug. In isoquinoline long-acting non-depolarizing drug, we have rapacronium, in isoquinoline long-acting drugs, we have mivacurium, and in steroidal we have rapacronium. One point I have to mention here, the drugs which ends with cronium, those are steroidal drugs. See, cronium, steroidal drugs. Cronium, steroidal drugs. If any drugs ends with cronium suffix, that is steroidal drugs. And if any drug ends with curium, these are isoquinoline group of drug. The first non-depolarizing neuromuscular blocker which discovered was curare. South American people were using this curare for hunting and paralysis of the animals. After that, we discovered D-tubocurare. We were using D-tubocurare, but because of some adverse effect, nowadays we are not using D-tubocurare. We are using some other drugs of non-depolarizing neuromuscular blockers. This was about classification of non-depolarizing neuromuscular blocker. After classification, what we should know about neuromuscular blocker is their mechanism of action. As I have explained, these neuromuscular blocker competes with acetylcholine for binding to nicotinic receptor. All neuromuscular blockers are bulky quaternary amines. They bind to the site of binding for acetylcholine, and they prevent binding of acetylcholine to its site of binding. When we give them in lower doses, this will be the effect. But when we give these neuromuscular blockers in higher doses, they will block opening of sodium channel, and by blocking the opening of sodium channel, they will cause more relaxation of the muscles and more paralysis of the muscles. One clinical point is here, we have enzymes. All you know about this enzyme which cleaves the acetylcholine, and that is acetylcholine esterase. These acetylcholine esterase, they cleave the acetylcholine and terminate the action of acetylcholine. Now, if we use some drugs which can inhibit the action of these acetylcholine esterase, This will lead to increase in the concentration of acetylcholine in the neuromuscular junction. Now, acetylcholine, because it has higher concentration, it will compete with neuromuscular blocker. It will remove the neuromuscular blocker from the receptor, and acetylcholine itself will bind to its site of binding. So what is the clinical point? To reverse the action of neuromuscular blockers, we can use drugs which inhibit acetylcholine esterase enzyme, which leads to higher concentration of acetylcholine in the neuromuscular junction, and this higher concentration of acetylcholine removes the neuromuscular blocker from its from nicotinic receptor, and acetylcholine itself will bind to nicotinic receptor, and then we can see depolarization of the muscle. But when we have given higher doses of neuromuscular blocker, and that higher dose has blocked the sodium channel, even if we give acetylcholine esterase inhibitor, these drugs are not able to open this channel again. In that case, we cannot see the polarization of muscles, and we cannot reverse the neuromuscular action after giving these drugs. This was the clinical point which we should know about it. In lower doses, to reverse the action of neuromuscular blockers, we can give acetylcholine esterase inhibitor, but in higher doses, if toxicity has occurred, we cannot reverse the neuromuscular blocker actions after surgery. Okay, I explained that these neuromuscular blockers block the nicotinic receptor. They inhibit flowing down of sodium. They prevent flowing down of sodium. They prevent depolarization of the muscles. What will happen? It will lead to repolarization and paralysis of the muscles. And paralysis of the muscle first starts by rapid contraction muscles, like rapid and small contractile muscles, like the muscles in the face. First, we can see repolarization and paralysis of the muscles of the face. After that, muscles of the fingers, muscle of the limbs, then muscles of the trunk, muscles or intercostal muscles, and lastly, we can see paralysis of the diaphragm muscles. Now, when we use acetylcholine esterase inhibitor to reverse the neuromuscular blocker action, the effect will be reversed. It means that first we can see contraction of the muscle, contraction of the diaphragm muscles, then intercostal, then trunk, then limbs, then finger, and then we can see the contraction of the muscles in the face and lips. This was about the mechanism of action and the action of non-depolarizing neuromuscular blockers. The main indication of neuromuscular blockers is we use these drugs before surgery to relax the muscles of the airway to facilitate the intubation. This is one of the main indications of neuromuscular blockers. These are safe drugs. These can decrease the dose of the anesthetic agent. By decreasing the dose of the anesthetic agent, they can decrease the adverse effect of these drugs also, and they can cause faster recovery after surgery. These are the advantage of neuromuscular blockers when we use them before surgery. But in addition to this action, these drugs has shown that they have some other actions also. For example, the curium drugs, they can increase releasing of histamine, and they can cause bronchoconstriction of the airways. Pancuronium has shown that it can bind to the muscarinic receptor, especially M2 receptor, and it can increase the heart rate, as well as it can increase the force of contraction, as well as blood pressure. They have shown that they have some other or additional actions also. They have action on the GI, they have action on the urinary bladder, and they can block those muscarinic receptors also. This was about the action as well as mechanism of action of non-depolarizing neuromuscular blocker. Another thing we should know about these drugs is about pharmacokinetic of non-depolarizing. Because they are quaternary amine, we cannot administer them, or we cannot give them to the patient by oral route. The route of administration for these drugs are IV route, and we can use them also in IM route also. The metabolism for these drugs, these etracurium and cis etracurium, we have Hoffman elimination for them, and they undergo a spontaneous hydrolysis. So etracurium and cis etracurium, and cis etracurium, they undergo Hoffman elimination. Hoffman elimination. What is Hoffman elimination? Hoffman elimination is a spontaneous rearrangement of these two drugs. A spontaneous molecular rearrangement which leads to inactivation of etracurium and cis etracurium. One of the metabolites of etracurium is lodanosine. Lodanosine. This lodanosine can cross blood-brain barrier, and by crossing the blood-brain barrier, it can cause seizure. This is one of the side effects of etracurium. Another drugs in non-depolarizing neuromuscular blockers are rocuronium and vecuronium. These rocuronium and vecuronium, we can eliminate them in the bile. We can excrete them in the bile. So in the bile, we can excrete rocuronium and vecuronium. These drugs, we can excrete them in the bile. Okay, this was about the pharmacokinetic of non-depolarizing neuromuscular blockers, and I have explained that to reverse the action of non-depolarizing neuromuscular blocker, we can use acetylcholine esterase to reverse the action. The last point about non-depolarizing neuromuscular blocker is their drug interaction. They have shown that they have interaction with some drugs, especially with acetylcholine esterase inhibitor. This acetylcholine esterase inhibitor, by increasing the acetylcholine concentration in the neuromuscular junction, it can terminate the action of neuromuscular blockers. So drug interactions are one, acetylcholine esterase inhibitor. The second, these halogenated hydrocarbon, which we use them for anesthesia, they can augment the action and effect of neuromuscular blocker. Aminoglycoside also can augment, calcium channel blocker can augment the action or effect of neuromuscular blocker. So drug interactions, I will write it here only, drug interactions, acetylcholine esterase inhibitor, they can reduce or they can terminate the action of neuromuscular blocker. The second, aminoglycoside, they can augment the action. Calcium channel blockers and halogenated hydrocarbons, they can augment, these three can augment the action of non-depolarizing, and this one it can decrease or reduce the action of or it can terminate the action of non-depolarizing drug. The next group of neuromuscular blocker is depolarizing neuromuscular blockers. Depolarizing neuromuscular blocker, we have only one drug, that is succinylcholine. And this succinylcholine, it can bind to the nicotinic receptor, and by binding the nicotinic receptor, it can open the sodium channel, and by opening the sodium channel, we can see flowing down of sodium into the muscle cells, which leads to contraction of the muscle cell. But how we are using these succinylcholine to paralyze the muscle, to relax the muscle? See, when we use high doses of succinylcholine, or when we use this succinylcholine for long duration of action, the first phase of action for succinylcholine is opening of this sodium channel and contraction of the muscle. That is phase 1, which leads to fasciculation of the muscle. But when we use them for long duration of time or for higher dose, this sodium channel will not open after a long duration of time. And even if we use succinylcholine and this succinylcholine bind to its site, these sodium channel are exhausted. They will not open after that. And when they will not open, this will lead to relaxation or paralysis of the muscles. And that is phase 2. So by giving succinylcholine, we can see 2 phases of action, phase 1 and phase 2. The first phase, as I said, is fasciculation phase. Fasciculation phase. And the second phase is paralysis or relaxation phase. Paralysis or relaxation phase. This was about the action, the mechanism of action of succinylcholine. The indication for succinylcholine, we can use succinylcholine for surgery to facilitate the intubation. We can use them for preventing trauma in electroconvulsive therapy. We can use these drugs for spastic condition, and we can use this drug for ventilation. These are the indication of succinylcholine. The last thing we should know about succinylcholine, which is important also, it's about adverse effect of succinylcholine. Adverse effect, ADR. Adverse drug reaction. The first adverse drug reaction is apnea. It can cause hyperkalemia. So we should be cautious about this when we are giving drugs such as diuretics or digoxin to the patient. The most important adverse effect is hyperthermia. These are the adverse effects when we use succinylcholine to relax the muscles before surgery in any patient. Okay, this was about today's lecture. Today's lecture we studied about the neuromuscular blockers. We classified neuromuscular blocker into 2 groups, non-depolarizing neuromuscular blockers and depolarizing neuromuscular blocker. In non-depolarizing, we have short-acting, intermediate-acting, and long-acting. In depolarizing neuromuscular blocker, we have only one drug, that is succinylcholine. And this succinylcholine, it shows 2 different actions, which we can classify in phase 1 and phase 2. In phase 1, it causes fasciculation, and in phase 2, it causes paralysis and relaxation of the muscles. In next lecture, we'll talk about the adrenergic system.